But I just want to emphasize that our immunization program has a lot of work to do. Every year, 7 million children are born. And that means that 7 million children need to be vaccinated. So that's a lot of work on the hands of the NPHCDA. And the government's goal is to have 85% coverage of Penta 3, which is the third dose of the pentavalent vaccine. We have not reached the 85%, but I want to say today that it's very clear that the program is making progress. Most of you have heard of the NICS mix results, the famous 33% coverage, right? I guess what you haven't heard is that 2 years later, there is another survey, the SMART survey, that's showing that the Penta 3 coverage has actually increased to 54%. So we're making progress. We're making progress. But we're not there yet. We know that still millions of children are under-vaccinated. Prof quoted 4.3 million, 4.5 million children. Prof quoted 4.5 million children, and with the 54% coverage, that has reduced. But then, like he said, any child that's not vaccinated is one too many, so we have to continue pushing. But the majority of these kids who are not vaccinated, you will agree with me, like what has been discussed, they live in rural areas, they live in urban slums, they live in hard-to-reach areas, and I want to add something again. They are children of poorly educated mothers. Do you know that the single most important determinant of whether a child gets vaccinated or not is really not where she lives, is whether her mother is educated. 3 times less likely to be vaccinated if the mother had a secondary school education versus if she didn't have any. So when we're talking about cross-sectoral collaborations, I didn't hear much about education. We really need to have a long-term view about improving immunization coverage. So there are some short-term things that we can do, which fixing the supply chain, talking to fathers, and adopting a community. But I think the thing that will make the difference long-term is really making sure that every woman, every girl gets educated. It's from her own education that she can drive the behavior change that will get her children vaccinated. The routine immunization vaccines in the program, what are they? I would imagine that most people here already know what they are, but just in case you don't know, I'll show you. So there they are. This is a picture made by NPHCDA and partners, and I think it's really nice. This is World Immunization Week. This is something that you can, share on social media so that people will see it. So there are essentially 9 vaccines in the routine immunization program, and a child is supposed to have 5 visits from birth to 9 months to complete the schedule, and that will cover 10 antigens. So currently 9 vaccines, but in the next 9 years, there is a plan to introduce 6 new vaccines into the immunization program, right? So, meningitis, ACWY, which has more serotype coverage than Men-A. Rotavirus is planned to be introduced this year, actually. Then there's a second dose of measles that's planned to be introduced. So most of our immunization program stopped before age 1. But the government is trying to now establish what we call a second year of life platform for immunization. So from the second year, the children are also supposed to come back and get their second dose of measles vaccine. And then HPV is planned also to be introduced into the immunization program. If you look down at the last bullet, there is discussion about introducing MMR as well as typhoid, but these have not been concluded. So it's somewhere in the horizon. So with our 9 vaccines and 6 more to come, what you see is an expanding immunization program that's getting more and more complex with different age groups that you're reaching. So you're reaching infants, you're reaching children in their second year. With HPV, you're reaching adolescents. Tetanus, you're reaching pregnant women and women of reproductive age, and so on and so forth. All this will cost a lot of money. So the title of this talk is Beyond Procurement. What is it costing us to procure our vaccines? Nigeria recently developed a 10-year strategic plan called the NCIPS. So this plan has calculated what it will cost to run our immunization program for 10 years. When Prof. Tomori was talking about Nigeria begging for an extension at Gavi in Geneva, I was actually with him then, and we're running around trying to make sure that all the things that needed to have happened here had happened. And they looked at this plan and they were happy with the plan. I think one of the reasons that they gave Nigeria an extension is just because of the sheer number of children who are unvaccinated. 4.3 million children, the highest in the world. Those were some of the reasons that were put forth in the discussion of the plan. However, what this plan means in essence is that in the next 10 years, the Nigerian government is going to spend nearly $2 billion to buy vaccines. So at the rate of 360 naira to the dollar, that is 700 billion naira that will be required for us to buy the vaccines that we need. Gavi will support with about $700 million within this same time period. But the bulk of the money, the bulk of the financing has to come from government. So when Gavi stops supporting us, when we graduate from Gavi support, it's estimated that we'll require around $300 million every year to buy our vaccines. That's approximately 106 billion naira per year to buy our vaccines. So I have a question for you guys. Can you tell me how much we currently budget for vaccines in our national budget? You know, the federal government pays for all the vaccines that are provided in the public sector. Can anybody tell me? So 21 billion, if that's the number, is the highest that has ever been budgeted for immunization. It usually is around, for vaccine procurement, is around maybe 12 billion, 6 billion. But that's where we are heading, 106 billion per annum. So when we talk about procurement, beyond procurement, we're not yet beyond procurement yet. We still have to continue the advocacy to ensure that the procurement happens. So that was the point of this slide. So we're now going to the vaccine supply chain. Like I said before, no product, no program. No vaccine, no vaccination. The vaccine supply chain is the backbone of the immunization system, because we know that, like I said earlier, vaccines have to be kept within certain temperature range, and the supply chain ensures that happens. But the supply chain includes the people who forecast the vaccine, who manage the cold chain and all that. It includes the storage, that's the cold rooms, the fridges, the freezers, the vaccine carriers. It also includes the temperature monitors, the monitoring spirits that make sure that the vaccines, when they're in the fridges, they're in the right temperature. The transportation, the forecasting, the stock management, and the waste disposal systems. So, for you to know that your supply chain is functioning well, it has to have 5 right things. So 5 rights. It has to have the right vaccine at the right condition, that's between 2 and 8 degrees Celsius, at the right place, at the right time, and at the right quantities. So these are the things that the supply chain strives to ensure. And in our increasingly complex immunization program, we have to get it really tight to ensure that from the point of manufacture to the point of delivery, the vaccines are delivered potent and intact. So to give you a brief overview of the Nigerian supply chain, there are different stakeholders in the supply chain. The federal government pays for the vaccines with support from Gavi. There's a national logistic working group that's led by the NPHCDA and has other partners. In the end, you see the other partners. Those are the ones that provide the technical leadership for ensuring that the supply chain functions well. Then UNICEF Supply Division procures all the vaccines for the Nigerian government. And then when the vaccines are procured, say they are bought from India, a lot of our vaccines come from India, they are air freighted, most of them are air freighted, the vaccines, the doses themselves, to the National Strategic Cold Store. The National Strategic Cold Store is very close to the airport. When you're coming out from the airport, when you're going to the airport is on the right, just before you get to the gate. Now the National Strategic Cold Store, the way the cold system is designed is going to change, or it has changed, is that from the National Strategic Cold Store, vaccines are moved to the zonal cold stores. There are 6 in the 6 geopolitical zones. Then from there to the states. Then from the state, the local government cold stores are supposed to come to the state to pool vaccines. So we are operating a mixture of a push and a pull system for immunization. And that has its own problems. Then from the health facilities are to go to the local government area to pool vaccines for their sessions. But there's a redesign that has changed that to push, and I'm going to talk about that. So with the way the supply chain is designed, there are a lot of challenges that have to do with the people, the storage, the distribution. So if you take stock management, for example, which is one of the things that needs to happen. If you're managing a vaccine cold system, you have to take stock. You have to know how many vaccines are coming in. You have to know what date they come in so that you would distribute the older vaccines before the newer ones. So for stock management, one of the major problems that had been the poor visibility around data. So let's say in the earlier part of this decade, cold chain officers at both the national and state level did not know what was happening at the LGA level. So it was like flying a plane blind. So there was a lot of challenges with lack of information coming from the lower levels. Vaccine accountability has been very poor too. I'll give you an example. For many years, we had been budgeting of forecasting and procuring vaccines at 80% of coverage. But when we do surveys, we find 30%. We find you procure at 80%, and you do coverage and you see that is 30%. Then the question now arose, what happened to the 50%? What happened? Where did all the vaccines go? So there are stories about some people, throwing away vaccines or whatever, but it's not clear what is happening to the vaccine. So there's a big issue around accountability that's being addressed now. And then I remember in 2011, around that time when we started this work, vaccine stockout was a common refrain. In 2011 particularly, there was a massive stockout of Penta. It was DPT-3 then at that time. There was a massive stockout of DPT-3, both in the north and in the south. But one of the reasons for that really was lack of information, poor stock management, and those stockout rates were high. Now, when we come to storage, You know, you have to have a place where the vaccines are stored, the cold rooms and all. We don't have sufficient capacity for storing vaccines, particularly at the lower level. The Nigerian government has a plan that every ward should have a health center that's equipped with a cold chain equipment so that there will be vaccines in every ward. But we're not there yet. And at the time this was assessed, only 15 to 25% of the wards had the cold chain equipment. Who knows how many wards there are in Nigeria? 9,565, close to 10,000. So that's the number of wards in the country. That means that we need to get to 9,565 cold chain equipment in the country to reach that 100% saturation. Another problem was inappropriate use of cold chain equipment. Yes, fridges and freezers are part of the cold chain equipment, but not your domestic fridge. So when this project started, some people were using domestic fridges, which is wrong. Poor maintenance. One other big problem with the stock out that was noticed at the peripheral level was that, remember I told you that health workers were supposed to go to the LGA to collect vaccines, but nobody was giving them money to do that. So a lot of the vaccine collection fell on them. So they will use their salaries to go and pick vaccines. And sometimes they will not be paid salaries. They'll be owed salaries for months. And obviously, there is no way they could go collect the vaccine. So that was a big issue. And then finally, the people who run the cold chain system did not have the training. Chika said we should stop using capacity. So they didn't have the right training. And so they needed to gain expertise in how to run a cold chain system. So these were the problems. So what did NPHCD and partners do? So they set out to do what they call an end-to-end transformation of the supply chain. And there are 4 main things that they wanted to do. Number 1 is improve stock visibility. Number 2, increase cold chain capacity. Number 3, instead of having health workers come to the local government area, instead they contracted third-party people to go deliver the vaccines from the state cold stores to health facilities that had cold chain equipment, cutting out the local government's cold chain. And then finally, build leadership capacity in the system. So this is a very simple and it was very effective. It was a very simple and effective intervention to give visibility to what was happening at the local government level. This is the dashboard, the supply chain dashboard. It's very simple. What they did was to train the local government cold chain officers. Every week, they would take stock, count how many vaccine doses they had, and then text that information to the state level, and then actually text it to the central server. And right from the national level and the state level, they could see how much vaccines were in place. And with that, it was like magic. It reduced stock, it improved stock adequacy, reduced stock out rates, and just generally changed the system. Because now, from the national level, you could find out that in Mubi local government area, they were going to run out of vaccines in 2 days' time. And action was taken immediately. So this dashboard now has evolved into an online platform called Navision. So Navision has taken over this dashboard and the work continues. The cold chain equipment was, the capacity was improved. The first thing the government did was to do a redesign. This is the supply chain redesign that I believe is still ongoing. There is funding for it, but they haven't fully implemented it. So instead of having one national strategic cold store that now distributes to the zones and then the zones to the states to the local government area, they decentralized that. So vaccines will now come directly to Abuja, Lagos, and Kano, and then from those 3 hubs, it will go to the states. So you see, in supply chain, they worked a lot with people like Coca-Cola to try to understand how is it that you can find Coke in the most remote place, but you can't find vaccines. But there was a lot they had to learn from the private sector. And one of the things they learned is that in supply chain, the more nodes you have, the more inefficient it is. So with this design, they cut out at least 2 layers from the supply chain. Now, the next thing they did was to just procure and buy and repair cold chain equipment. So that raised the saturation from 17% to 16%, 66% right now. Then a lot of the equipment that were bought are using solar. So that takes care of the erratic power supply situation. A lot has happened in the supply chain in Nigeria, and kudos really goes to the MPHCDA. People may not know this. I was telling Uche earlier on when we sat down that much of this success really needs to be communicated so that people know the progress that is being made. And I think it encourages us to know that it's not all about failure. It's not all about the system not working. These are some of the things that are working. Of one of the strategies that worked. So in this paper by Uche's team, they show that when Kano State contracted third parties, that's transporters, to deliver vaccines to the health centers. So what they did was they delivered the vaccines to those that, remember I said there's a plan to have one health facility per ward that has cold chain equipment. So they had transporters deliver the vaccines from the state directly to those health facilities. When they did that, you can see the graph, you can see there was an increase in number of vaccinations. So not only did they not have stockouts, more children were vaccinated as a result of that simple intervention. And so for those health facilities that did not have cold chain equipment, what they now did was they would go and collect their vaccines from their neighboring equipped health facility. So this is another intervention that worked. Those are the 3 examples. Then the other things they did was to really set up a logistic working group and really strengthen it at both the national and then the state level. But there are still some challenges that are remaining within the supply chain. Number 1, the vaccine accountability is still an issue. But one of the things the government is doing now, they have this innovation called Follow the Vaccine, where they are tracking the vaccine from the vaccine vials themselves. They are tracking them from the national store to finally where they are being used. That's number 1. The other thing they are doing is, previously, when health workers collect vaccines, they only account for the number of doses they vaccinated. They don't return the vials. So, but now, they are made to return the vials, and they are counted. The number of vials you receive is compared with the number of vials you return. So that's going on right now. The other challenge is that we already know that direct delivery works, but that hasn't been scaled up yet. And the challenge is funding. The state government has to take that on, but is yet to be seen to what extent other state governments will take this initiative on. Another challenge is the, should I say, lack of integration. You know, vaccines are not the only things that get to the health facilities. Medicines do as well. But there's been an effort to try and see if we can integrate both the medical supply chain and the vaccine supply chain. That hasn't happened yet, but the idea is that if you can do that, then you could reduce cost and improve efficiency. And the final challenge that is still on the table, being a, should I say, vaccine financing advocate, I have to say this, is the fact that we still need 76 billion naira over the next 9 years to implement the supply chain improvements that are still in the plan. So we can't relent until we are sure that this funding is going to be made available. So quick tour of what else is happening in terms of supply chain innovations. Last year, the Gates Foundation put out a challenge grant. I don't know how many of you know the challenge grant, Gates Foundation challenge grant? 1, 2, 3. Okay. So every year, the Gates Foundation throws out a challenge to people. They may identify a problem like how do you improve demand, how do you improve supply chain, and anybody, anywhere can apply. If you apply, I think you have to have an organization or so. If you apply and you get it, you get $100,000 to test out your idea. And if that works, over 18 months, if that works, you can go for bigger grant to scale it up. So these are two challenges I pulled out. The first one is using blockchain technology to using blockchain technology as a database to estimate how much vaccines are going to be needed in a system. And blockchain technology, as you know, is a very solid database. It's very hard to crack. So the idea is that if you can use such a robust system, then it will minimize efforts to either falsify information or things like that. The next one is using machine learning to project or to estimate how many doses of vaccines will be used. That's been done in Tanzania. So machine learning is just something that happens even on your phone, on your iPhone, right, or your Android. When you type something, after a while, you don't need to type the name again. It just pops up. That's because your phone has learned your typing habit. So they are using all the data, big data, to crunch the numbers, to project how many vaccine doses will be needed. And it seems promising that it could be more accurate than the type of projections that we do right now. And then finally, Zipline. I think this is launched today. So Zipline is this group. I think they are based out of Uganda, Rwanda also, not sure. Rwanda, yes. So they are using drone technology. Right now, they are using it to deliver blood products. So remember, can you imagine if there's an accident now, somebody needs a blood transfusion, and it will take 4 hours or so to drive blood to the place. So they're using drone technology to shoot out the blood. So they're in Ghana today. They are testing whether they can use this to do vaccine deliveries. That reminded, when I was doing this slide, at the same time, there were all these planes flying over. I think the Air Force was having some kind of exercise or so. And I was wondering if that was what will happen when you start sending drones with vaccine vials all over the place. Anyway, so drone technology. There's also one I read about. It's like you're going to talk about one too. There's one I read about where it's called a pot in a pot. Is that yours? You started from there. So the idea is that there is a pot that sits within another pot, and in between the two pots there is sand, some kind of thing that will retain water. And when the breeze blows or when air passes, the water evaporates and then the pot inside cools. Do you know what that reminds me of? When I was in secondary school in Yola. Yola is very hot. We used to make refrigerators out of bottles. So you take either Fanta bottle, put water in it, then wrap it in toilet roll or whatever, clean one, and then put water on it and let it stand. So as the breeze blows it, your water will cool. So it was so interesting to see that somebody had used this for vaccine technology. So So those are the ones I wanted to share with you. So in conclusion, I want us to remember that for the supply chain, there are 5 right things that we need to do. The right vaccine at the right what? In the right, at the right time and the right quantity. So that if you can get that, you got your supply chain right. And the national vaccine supply chain is undergoing transformation, and to make it more robust to the more complex immunization program that we find ourselves in. Some of these innovations will transform the supply chain system to make it ready for what is to come. But there are also some new innovations that are available outside that Nigeria could prove an important place to test because of the complexity. Because if it can work in Nigeria, it can work anywhere else. But we still need money to make sure that those plans come to fruition. So we also need the advocacy to secure the funding. And then finally, we need to work better at integrating our supply chain so we can gain efficiencies and synergies. So those are the main things with our supply chain. I want to thank all the vaccine supply chain partners. Thank you very much.